HealthEast has looked at delirium as a high priority in 2014, and so we have gathered a multidisciplinary group to look at delirium and how it impacts our patients at HealthEast.
Delirium is a devastating problem for patients in hospitals. First, people who develop delirium in a hospital stay in the hospital longer. Studies say that they would stay 8 days longer than somebody who does not develop delirium. The other thing that's really worrisome is people who develop delirium, their rate of dying in the hospital doubles.
We've had patients tell us, I just don't understand why I'm thinking this way. And I know that there's not ants crawling on I know that they're not crawling on the wall, but I see them crawling on the wall.
We're sending them home physically better, but not mentally better. So we really want to reduce the incidence of delirium so that we are sending them home as, in the best condition that we can.
And then it's just a very costly problem. Studies have shown that people who develop delirium, they spend at least $16,000 more per year, maybe $64,000 more per year on healthcare costs compared to people who do not develop delirium. Healthcare systems have typically reacted to delirium once it's occurred. And in that case, the cow's already out of the barn, so to speak. You already have a big problem, and you're trying to undo the problem. Really, the frontier is to identify people at risk and intervene in some way to prevent the problem from developing. And so, like everything in medicine, it's prevention. So you can often identify who is at risk for delirium prior to entering the hospital. And so there's a validated instrument that was published in the medical literature called the Delirium Elderly at Risk Tool, or DEAR tool. And patients can be assessed for historical factors that put them at risk for delirium. The biggest one is a known history of dementia. So if a patient has a history of dementia, that puts them at incredibly high risk for developing delirium in the hospital. Other risk factors are older age, and so 80 years of age is the arbitrary cutoff in terms of older age. Sensory impairment, so if people need glasses in the community or they need hearing aids in the community, that puts them at risk for developing delirium in hospitals. People who need help caring for themselves, so if they have functional needs like bathing, eating, dressing, if they need help with those sorts of things, that puts them at risk for delirium.
So when a patient first comes into surgery, they're screened there using the DEAR screening in the surgical admit unit. So if they're positive for that, then they would come onto our unit and they'd have this pink sticker on the chart that would let all of us know that they are high risk for delirium. Some of the same interventions that we use for a patient that is in delirium, we use to prevent delirium. We would make sure they're up in their chair for meals. We walk them throughout the hallway during the day. We make sure their family's present and their family is involved and they know about, delirium and how to prevent it.
In addition, family members can bring in items from home that the patient would find familiar and comforting, such as photographs, maybe a favorite blanket or throw. We want to make sure the patient can experience the environment accurately, so we make sure the hearing aids and glasses are on during waking hours. Keeping the blinds open during the day keeps day-night orientation. Also, we try to have the nurses avoid certain medications, that can add to risk of confusion.
Well, we do have this assessment that we do on patients. The abbreviation is CAM. It's the Confusion Assessment Method. And we do it on patients who are 65 or older. We do it once a shift, and there's 5 different things we look for. The first one is an acute change. So is there an acute change in the patient's, behavior, or is it worse than it was? And then the second one would be, is it a fluctuating course? Does it fluctuate throughout the day for the patient? Does it get worse and then get better? And then the third is inattention. Does the patient have problems focusing attention to the conversation or during an activity? The fourth is disorganized thinking. Does the patient have trouble following the conversation? Are they rambling? The fifth would be altered level of consciousness. Do they sleep more during the day? Are they awake during the night? Or they have their days and nights mixed up. If we do have a patient that is in delirium, we put a sheet of paper that has a DEAR on it outside of the patient's door to let everyone know that that patient is in delirium.
as we're talking to nurses now and doing education, there's so many things that they have already seen and experienced, and to see the light bulb go on when we're talking about delirium and, oh, that was my patient, they're recognizing those things, is really incredible to know that going forward they're going to be able to recognize it early, take steps, educate the patient when they can, and educate family members on what delirium is, how to recognize it, and what this is doing to the patient. Research has been done on delirium tells us that patients who experience delirium in the ICU have higher morbidity, higher mortality, and longer length of stay. And we're really focusing on 3 key elements that impact delirium. Sedation, so looking at how we sedate our patients on mechanical ventilation. Mobility, how soon are we moving them, getting them out of bed when they've been suffering from critical illness. And environment, so looking at things in the environment that impact our patients and could cause disorientation.
Well, there's something you learn almost your first day of medical school. First, do no harm. So in your effort to help people, don't harm them. And this delirium project is one of those examples. When you come to us for care, we don't want to harm you. We don't want to do things to you that cause delirium and cause you to stay in the hospital longer and make you sicker.
We would like to see patients not end up with delirium, be their normal selves when they leave the hospital, and not have long-term effects from being intubated or hospitalized.
Delirium is difficult to recognize, it's difficult to manage, so having this focus on prevention of delirium rather than treating it after the fact is really going to make a difference for our patients here. It's very important work. It can really have an impact on our patients' lives, and we are saving lives by managing delirium appropriately.